We're going to start off. Our first session is with Dr. Mark Coleman, and we have Dr. Sunrath Patel from Averitas Pharma. They're going to be talking about a new innovative way to treat painful diabetic peripheral neuropathy. So come on over.
Okay, great.
All right, welcome. How are you, Mark?
Again.
How's it going?
AJ,
Sunrath?
good to see you. Anthony.
Thank you to come.
Outstanding.
Good to see you. Thanks for
you so
coming
much.
down.
All right, great.
So
That's all
there's your
yours.
slide.
Okay, all righty. So today we're going to talk about QUTENZA, which is a topical system for the treatment of diabetic polyneuropathy. Now, diabetic polyneuropathy has really come to the forefront of interventional pain management, and much more attention has been paid to this really important disease condition that affects so many people. So one of the big points that I need to mention today, and the reason why we're here, is that QUTENZA is the type of treatment that you can't simply write a prescription and give it to the patient and they apply it on their own. It has to be applied by a skilled healthcare practitioner. Now, that can be anybody in the treatment paradigm. It can be a medical assistant, a mid-level practitioner, or it can be the physician himself. But that being said, the treatment does contain high concentration capsaicin, which can be caustic to the mucous membranes, respiratory tract, and eyes. So you really need to be careful with this medication.
So one question I have for you, when we just said high concentration capsaicin, right? Capsaicin cream sold in Target, right? So I know you're going to get to it, but a lot of people out there say, oh, I can just get capsaicin cream. So I'm excited to see how this is different and how going forward this can help patients way more than just the over-the-counter version.
Yeah, I wish we had a ton of time for this because this is really kind of complex.
Yeah.
So as you know, capsaicin, the hot element in chili peppers, is lipophilic, okay? So to the extent that human beings are 98% water, those creams that you apply to the skin don't really penetrate.
Yeah.
The QUTENZA preparation, it has a special delivery system which sucks out the water, and it creates a concentration gradient where the capsaicin actually is driven deep into the epidermis. So that's why it works so well.
That's awesome.
That's great.
Yeah, so I'd like to move on to the mechanism of action. A picture is 1,000 words, and QUTENZA is meant to be used once every 3 months, and the reason why it works so well is that its active ingredient, capsaicin, attaches to the TRPV1 receptor on the small nociceptors, the C fibers and the A deltas. So when you apply the patch, you get an initial sensitization. And quite frankly, I haven't seen too many patients feel this, but if there's any broken skin or any ulceration, the patients can feel this. It's very, very short-lived. And then there's a desensitization. Once the capsaicin attaches to that TRPV1 receptor, there's an influx of intercellular calcium, and the nerve essentially slows down and stops working. Longer application causes a defunctionalization and a rescission, meaning that the actual nerve fibers recede back from the epidermis and go into the dermis. So they're really not functional anymore. And then over the ensuing 3 months, those nerve fibers start to grow back, and about 2.5 months or later, the patients start to feel the pain coming back, and they need a reapplication.
So a lot of us are accustomed to radiofrequency ablation.
Right.
You are denervating a peripheral nerve, and that peripheral nerve grows back over time, and
Yes.
that's why we tell a lot of our patients you might experience pain relief for months, maybe years.
Right.
And then when it regrows, you might need a repeat treatment.
Right.
So this is almost like the same thing, but for diabetic neuropathy.
And no needles.
And no needles.
And no
Right,
needles.
Right.
And it's
much
not
easier sell.
And you asked about the topical creams. Even if they did work, even if they were highly that's a 3 times a day application.
Yep.
Your patients are coming in once, and they come in 3 months later. So
Yeah, it's great.
very easy on the patient.
Very good.
All right, next slide. All right, so people ask, well, what is the evidence? Okay, so let's go through. I'm not going to give a recitation of the whole STEP study, but about 400 patients were randomized QUTENZA versus placebo, and primary endpoint was basic pain score, measured at 2 weeks, 4 weeks, 8 weeks, and 12 weeks. Next. And as you can see, QUTENZA works as quickly as 1 week, and it's separated out from placebo by 2 weeks. And as you can see in that graph there, the separation was robust all the way through 12 weeks. So as you can see, there's good evidence for why this works. Now, in this trial, patients could remain on their standard of care. So there were some patients who were on their usual gabapentinoid, maybe gabapentin 300 TID or whatever. And there were a subset of patients who were using QUTENZA alone. And this is a post hoc analysis that shows that there's even more separation when patients are using QUTENZA alone. So that suggests that you can use QUTENZA both with standard of care or without it. So it implies that perhaps you can lower the systemic medications with a successful QUTENZA trial.
I think that's great because a lot of my patients come in and they're on the gabapentin. A lot of people say gabapentin is a pretty benign drug, but it causes drowsiness. You have people that are trying to work throughout the day and they can't take it 3 times a day. It also causes, we talked about the calcium channels, gabapentin works on that. It can cause swelling in the lower extremities, which I've seen to be profound.
Absolutely.
Unfortunately, then you can't use the gabapentin.
Especially in the elderly, which is the patient population that's more likely to have painful diabetic neuropathy.
Yeah.
So that's
tolerability and drug-drug interactions are the biggest things with the anticonvulsants, and this may provide an excellent opportunity to get away from that in this patient population. Okay, so we can kind of pivot from the slides and get to the application. That's what everybody wants to see.
Let's see how it happens.
Okay, so this is just like a cooking show, and I'm going to show you all the ingredients you need.
Here we go.
Okay, so you're going to need your patches, okay, and we've kind of pre-cut the patches so that we're not wasting a lot of time opening them up. Optional EMLA or lidocaine gel, some Coban, scissors, marking pen, and an ice pack. Okay. All right.
Now, do you prefer paprika or do you prefer, what's your spice of choice?
So we're using capsaicin.
Capsaicin. Okay. Just checking.
Okay.
A little capsaicin on your pasta, right?
Okay. So the first thing you want to do is ask the patient if they're sensitive to any topicals. Sometimes people with allergies to adhesives, or they've had a QUTENZA before, or they've got maybe micro breaks or something in the skin that you can't discern. Interview them and see. If that's the type of patient that you're dealing with, then I'm going to recommend a pre-treatment with a lidocaine-based gel or EMLA. And you would just apply that to the foot as you would for about 1 hour. And then you would simply wipe that off before you get started, okay? So.
Can you give that to the patient beforehand to apply before they come in the office, or you let them sit?
You certainly can. Now, one thing that you should do before you apply the EMLA cream is map out the area. You should have a pretty good idea as to where the patients are most sensitive. Most of the patients who've had they're on their first application are going to be sensitive everywhere, okay? But you take a Q-tip and you ask, hey, are you feeling sensitivity here? Is there allodynia here on the left, on the right? And you kind of do a map of the entire foot. On your first time you do it, I recommend that you draw a line where you're actually going to apply, and usually it's going to be just the forefoot here. Okay, so that's what this pen is for. And then every once in a while, you're going to have a Sasquatch patient who's got a lot of hair on the foot, and we do not recommend that you shave anywhere because that's going to cause some micro breaks in the skin, which could be very irritating to the patient. We recommend that you use some scissors and simply clip the hair down as much as you can. Now you're ready to apply, okay? These patches, they're just like any other patch where there's a adhesive and then there's a liner, okay? And there's a diagonal break on the corner, so it allows you easy access. If you're going to do any cutting of the patches, which you might do if there's an ulcer, if there's a broken skin, we recommend you measure it so that you cut through the diagonal area so you'll have easy access to the patch. So I'm just going to demonstrate how to put this patch on, which I know some of you guys are fellowship directors out there, and if your students are not catching on to the Scotty dog real quickly, you might want to put them on patch duty, because this is a procedure that anyone can do.
You got demoted to patch duty.
Yeah, patch duty. So, important to note, you're going to need to have your goggles on, mask, and nitrile gloves. Okay, these are all protective for you. The capsaicin can aerosolize, be in a well-ventilated area. You don't need a fan, just have the door open. So I generally put these on lengthwise. So I'll wrap around the toes first, and then I'll slide down to the sole of the foot.
How many patches are you allowed to use in one sitting?
Diabetic polyneuropathy is symmetrical, and for 99% of patients, you're going to be using 4 patches. It's going to be 2 patches on each foot. Now, you may find that there are some patients who their area of sensitivity starts to shrink with repeated application. So you might find patients who come in for their 3rd application and they say, hey, listen, I only need the top of the foot done, and that's fair game.
Good.
Great.
Okay.
And we're talking about the foot. Are you able to do this yet in the hands or anywhere else?
It's only on label for the feet, and it would be off label for any other area. And I would recommend that you speak to the MSL for off-label indication. So just to finish up here, I'm going to apply the dorsum of the foot patch to the dorsum of the foot. Now, you'll find that just because of the size of the foot and the curvature, that you may have to make some cuts, and that's perfectly fair game. So I'm going to make a couple of cuts just to make sure that the patch sits down snug.
Now you're wearing gloves, you have a mask, you have goggles on. What about for the patient? Sometimes you get these patients who get really excited about technology and they want to touch it. So do you put gloves on your patients, or do you just warn them, look, you can't touch this, it's off limits? Has that generally been pretty safe?
Yeah, we do not want the patients to get involved with the treatment at all.
Some of them get very eager, they want to help out.
AJ, it's like flying an airplane. There's always some smarty pants in the back says, hey, listen, what's the pilot doing?
The backseat driver, armchair quarterback?
No, don't mess with the pilot. We're going to be applying some Coban to apply some extra pressure to the patch and make sure that it lays down snug on the feet. Now, as I wrap this, I'm going to tell you a little bit about this patch. Now, I'm sorry. So the Zostrix cream and those type of preparations, they're about 0.1% capsaicin. This is an 8% capsaicin patch. Just to kind of put it in perspective for you, the hottest of the hot chili peppers is about 8,000 Scoville units. This patch is 20,000 Scoville units. Wow. So if you're not being careful, and for some reason or other you touch this patch and it touches the mucous membrane or eye, you remember that song, Jump Around by House of Pain? You will be jumping around and you will be in a house of pain.
That's right. That's right.
So it's very, very important to apply this properly. So now we're all done, okay? And the patient will sit with this arrangement like this for the next 30 minutes. Now, if a patient experiences any discomfort during the procedure, you have your ice pack here, and you ask them to apply the ice pack or you do it for them. Just from a standpoint of safety, because there are some patients who really emotionalize these things and they're making it up to be more than it should be, we recommend that you take a baseline blood pressure and a blood pressure about 15 minutes in. But this, by no means do you need constant monitoring or a pulse ox or anything like that. Okay, so the patient is done after about 30 minutes, and the next thing is removing. And I will tell you, removing a QUTENZA is easier than removing an SCS, okay? So I recommend along the treatment algorithm that you consider this, okay? So removing is just a matter of safety. You've got to have a red biohazard container in your office whenever you're dealing with QUTENZA, okay? So naturally, you're going to take the Coban off first. That comes off pretty easily. And there's a technique to, and again, you're going to be throwing this into the red biohazard. So there's a technique to doing this, and I recommend that you remove the patch and curl it underneath itself so that a minimal amount of active patch is exposed. And you must do it slowly because QUTENZA, this patch, it can aerosolize, and you really don't want that aerosolized capsaicin in the environment. So very slowly, you just remove the patch, and and watch how my technique as I roll it underneath. And you can see, like around the toes, it'll come off in a block. And you just
And so this is something
continue to
a
roll.
medical assistant could do, a nurse.
Absolutely.
You could have a nurse practitioner, a physician assistant, or a doctor. All of them are eligible to be able to provide this service, right?
Yes, absolutely, absolutely. I have done a few of these, but by and large, I've got physician extenders that are involved in this. Now, we're not done yet. So there is a special proprietary cleansing gel that you must use with this. And I'm not going to go through the whole thing, but it's just a little dab of it in the fingers. And you're going to have to change your gloves, spread it all around the foot, all the areas that were under contact. And then you take a gauze and you wipe it off, okay? And then the last step is that you'll do the same thing with soapy water.
Okay.
The patient should not be wearing flip-flops when they come in. Tell them to come in some old socks or whatever, and there's generally no discomfort or pain as the patient leaves the office. The biggest adverse reactions are just typical site reactions, so a little burning or pain. I've never seen a patient complain vociferously about this. They may notice it. They'll say, hey, listen, when I was in the shower the morning after my application, I felt the cold water was a little extra cold, or the hot water was burning a little bit more. But it's not a problem.
You know what's interesting? We used to use this a while back for postherpetic neuralgia.
Right.
And there, the Emla cream was much more needed. It was much more essential to numb that very tender, superficial skin area.
Yeah.
But for diabetic neuropathy, it's interesting that, you know, it's not as essential, it's not as needed.
Right. Well, you're dealing with a thicker skin, that's number one, and
Right.
the application time is much different. For postherpetic neuralgia, it is a 1-hour application.
Right.
So you can imagine after an hour that concentration gradient is really starting to kick in, and you're getting deep penetration. And as you know, postherpetic neuralgia is a much more painful disease with much more cutaneous nerve destruction.
Absolutely.
Where have you put this into your algorithm of treating painful diabetic neuropathy? So we know that there's a lot of things coming out now, which is great, because I say when a patient with painful diabetic neuropathy comes into my office, it's one of the hardest things to treat, and treat well, at least, right? You pump them up on gabapentin, you get them on Lyrica, desensitization techniques, paraffin baths. I always start with the desensitization techniques, right? Then I do the gabapentins and all that stuff, and now there's even more implants coming out for SCS and all that kind of stuff. Sure. Where do you use QUTENZA in your algorithm?
Yeah, well, most of the patients that come into my practice have already seen a primary care physician. So I've got to make an evaluation as to whether their standard of care is properly dosed. How many times have you seen a patient who comes in, they're 45-year-old diabetic on gabapentin 100 milligrams 3 times a day.
And they always say, it didn't work for me.
It didn't work.
Yeah, right.
I'd say it's like putting a cup of water into the ocean. Yeah, it's not gonna
I'd say
work.
it's water. You might as well just drink water.
It's not going to work.
So true.
Yeah, and then similarly, you're going to see these elderly patients who come in on 800 TID and say, like, after I take my gabapentin,
Right.
I don't leave the house because I'm
zonked.
run myself into a car. So you've got to evaluate the standard of care and then make adjustments. Any patient who continues to fail after standard of care, I offer this. Also, understand we're interventional pain management physicians as well, so you're going to have a lot of concomitant disease. So you're going to have patients who come in with a herniated disc with pain going down both legs, but their feet burn too. And you look on their medication list and you see insulin or you see metformin and you see gabapentin, and you're wondering why. Well, I get the legs, but the feet are still burning. And the knee jerk is like, oh, gee, I'll do some bilateral S1s, and you do that 50 times and it doesn't work. Well, gee, misdiagnosis, right?
Right.
So that's where I employ it.
Awesome.
That's great.
And for those patients, do you basically set them up to say, hey, in 3 months we're going to do this again, or do you just follow them up in 2 months and see how they're doing? How do you usually?
Yeah, so they're usually on the mid-level schedule, so we'll see them in about 2 months, and we'll make a determination. And what's interesting in one of the studies, and I didn't go through all the studies, but the PACE trial, it showed that patients who continue to get treatments, it tends to work better and better and better with time.
So even if someone the first time around just got like 20-30% relief,
Right.
you would keep that,
you keep
that makes
going.
sense to me, the way that the nerve kind of desensitizes.
It
That's
keeps going.
great.
And listen, there are going to be some patients where you're not getting a proper treatment effect, and they may have some concomitant disease where you may want to move on to neuromodulation, but you really owe it to your patients to try something conservative first.
No, that's great.
Whenever we do a procedure and you have a diabetic patient, you're checking a glucose.
Yeah.
So how many times have we canceled a procedure because someone's sugar was too high?
210.
Right.
I had an English muffin. It's like, yeah.
Right. I drank a
Orange
Coke
juice,
before I came in because I felt
Right.
So
And what's interesting to note about that is one of the harbingers of less ideal outcome in surgery is uncontrolled blood sugar. It's not necessarily hemoglobin A1C.
Yep.
So you got to remember that. So
snapshot
there
in
go.
time. You got to be
Exactly.
cognizant of that.
Exactly.
And when we cancel those patients, I think it's not just enough to cancel them. You've got to sit down and really help them understand what they need to do to reshape their lifestyle around their diabetes and better glucose management.
Right.
Because that will play a better part in their overall health, as well as giving them quality of life improvements with the QUTENZA patch. I think that's an important part of holistic care.
Great.
This is great.
This is really cool.
Really good. I'm excited for it. I haven't done this yet. I'm excited to bring it to my patients.
One thing that I tell people is I've been in interventional pain management 22 years now. So, and people say, oh, well, QUTENZA patch, well, gee, it's not an intervention. But at the same time, like every single patient you see with diabetes, I tell them they have 2 feet, 2 knees, 2 hips, 2 shoulders, a spine, and 100 friends that have pain as well.
Yeah.
Right.
So this is a great marketing tool for your practice, and you're doing good.
Yeah. And less is more. If you don't have to do a procedure, that's better for the patient.
And a lot of patients may not go for a large interventional procedure. It may scare them away.
Right.
And so if before you either did that or you did medication management, you didn't really have something to fill that gap. And now we do.
Yeah.
Right. You want to have a treatment for everybody.
There you go. There you go.
This has been great.
Great job.
All right.
Fantastic. Thank you very much.
I'm not going to shake your hand.
Oh, we'll do the
Yeah.
elbow. We'll do the COVID elbow bump.
There we go.
Thank you, Dr.
Thank you.
Patel. Thank you,
Awesome,
Dr.
man.
Coleman.
This is just a demo. This is
It's not the real stuff.